So my name is Abigail Johnston. It's hard to think back, but it has been more than 20 years since I graduated from law school. I graduated from law school in 2002, and I've been a licensed attorney in Florida ever since then. That all served me very well when I was diagnosed with stage 4 metastatic breast cancer in 2017. And I like to call myself a professional patient at this point because basically I go to the doctor and that's my job, as well as taking care of my kids and that sort of thing. And then dealing with all of the stuff that came with that on a personal level, I started seeing so many of the things that are broken in our system and how hard it is to access care. The healthcare system, whether you've got health insurance companies, your doctor's office, pharmaceutical companies, it is hopelessly confusing and hopelessly broken in so many ways that we need every advantage we can possibly find in order to navigate all of it. The health insurance can be divided into two buckets, which is private and government. And that is having to do with which entity is paying, is actually writing the checks to pay for whatever medical treatment has happened. Then we get into the government plans, which have a whole lot of different types of structure, right? Medicaid is usually the program that is offered to people who have, their income is what tied to the poverty level. So it's usually the poverty level times 100% or times 400% is usually how that is evaluated. But then you get to the point where Medicaid is both federal and state. Some states have expanded Medicaid, some states have not. That can be super complicated, and that is usually a place where you really need a social worker to help you figure out exactly what you qualify for, which programs you don't. And then we come to Medicare. So Medicaid is tied to income. Medicare has a whole lot of parts. Part A is the part that is offered for free once you're eligible for it, and that covers hospitalization. So the nice thing about that is that you can have Medicare Part A and private insurance at the same time, which is actually personally what I have. I have my private insurance through my husband, and then I have Medicare Part A. I go to the hospital, I pay $0 because Medicare covers whatever my private insurance doesn't cover. It's a very seamless process. It works great for me anyway. Once you get to B, and I think all the way to M, and they may be adding more parts of Medicare, the other parts cost money. And I always recommend to people who are transitioning to Medicare because of Social Security disability, or you can also get Medicare based on your age. 65, you start getting different types of benefits once you hit 65. Always sit down with a Medicare broker, because for those of us who are in the metastatic breast cancer community, our treatments, our medication, our doctors, our scans are all in the top tier. So the things that cost the most. And so I always recommend working with a broker because this is what they do. They have you list your medications, they have you list your doctors, they have you list your scans, and then they back into the policy or the part or the supplemental plan or whatever it's called, the thing that will cover you. Even to the point where I know some people where you will sign up for one thing for the first 6 months, and then you sign up for the second thing for the second 6 months because there's different benefits to the different parts or the different supplements. The people who are insurance brokers who specialize in Medicare, they are paid by the plans, so you pay nothing out of pocket. And I believe are really key in designing coverage that will actually cover what you need to have covered. I believe all insurance brokers have to have a license. And so you can always Google insurance brokers in my area with your zip code. I typically recommend that you look for a broker that specializes in Medicare, advertises that they specialize in Medicare, and then I suggest you ask, how many people with metastatic breast cancer have you worked with? Because it really is a bit of a niche. I have some insurance brokers that I work with that I send the people with MBC to them because I know that they have done the extra work to really understand metastatic breast cancers. One other thing that can be a little bit complicated is that most pharmaceutical companies have they will have a foundation, and then they will have specialized copay assistance programs. Now, copay assistance programs are designed to help you with your copay because we're in that top tier again, right? So even if you have an amazing health insurance policy, a lot of times you'll, based on the negotiations between the pharma companies and the health insurance company, you may end up in that top tier and have a significant copay. So if you have private insurance, the copay assistance programs can come in and defray that cost. Quite frankly, I think that's the least that they should do because the amounts of money that are being paid out by health insurance companies are pretty significant. The problem that many people encounter is when they are on either Medicaid or Medicare, you no longer qualify for those copay assistance programs. And the reason for that is how Medicare is able to negotiate with the pharmaceutical companies on behalf of everybody in Medicare. That means then that there are certain perks that are no longer offered because they've already negotiated as a good a rate as they can with the pharmaceutical companies. So at that point, some people will get a $2,500, $30, or $3,000 a month, $2,500 or $3,000 a month copay until they reach out-of-pocket maximums and those kinds of things. Regardless of what insurance company, policy, government, private, COBRA, whatever, regardless of what it is, the most important thing that people need to know about what they have is what it covers. And most insurance policies are going to be hundreds and hundreds of pages long. Typically, you can get that directly from the company, and typically they are searchable. So they are usually in PDF, and usually you can search for keywords. And there's a couple of key things that I think everybody should know. Number one is your deductible, right? That's the money that you have to pay every year before you hit your out-of-pocket maximum, before sometimes some benefits kick in. So that's the number one thing first. And realize there may be more than one deductible. So I have a deductible that applies to doctor's visits. I have a deductible that applies to medication. Different numbers. I have to meet both of those. I have to pay both of those things before my insurance kicks in. The second thing that's super important to know is your out-of-pocket maximum. So pretty much every plan I've seen, and I doubt there's plans that don't have this, but every plan says you have to pay up to X amount, and then the insurance kicks in either at a different level, different percentage, that sort of thing. So between your deductible and your out-of-pocket maximum, that's what you've got to plan to pay throughout the year before the insurance coverage typically kicks in at a higher percentage. So in addition to knowing kind of those big picture numbers, knowing other numbers like what kind of scans and how many will my insurance cover. So Medicare is the most restrictive. There's actually a lifetime limit on PET scans, which many cancer patients get. Again, sometimes, and quite frankly, a lot of times, the insurance company will challenge that order by saying, is this really necessary? Now, every doctor's office I've dealt with, they know how to deal with that. They schedule a peer-to-peer where your doctor is talking to a doctor that's hired by the insurance company. But here's something really important. Your plan says what you are entitled to in terms of that peer-to-peer discussion. What's a peer? Well, let me tell you, the first peer-to-peer conversation that my medical oncologist, who had 30 plus years of experience, she was talking to somebody who is a family medicine doctor who had been out of medical school like 5 or 6 years. Are those peers? I don't think so. And I objected and was able to have my doctor, unfortunately, she had to do the peer-to-peer at the second time, but they actually provided an oncologist with a similar level of experience. As a person who is paying the premiums, typically that is in your policy, and you are entitled to have the insurance company pay for a peer to talk to your doctor. In my experience, in dealing with a lot of these, and my own personal experience, when an oncologist is talking to another oncologist, things don't get denied as frequently. When your oncologist is talking to a family medicine doctor or a podiatrist or an ophthalmologist, somebody who has a specialty that's different from oncology, number one, there's a huge amount of education that has to happen there that your doctor shouldn't have to. Your doctor shouldn't have to spend the time justifying their treatment plan. They should be able to talk to somebody who understands what they're talking about. That is different from, if you're trying to do something experimental, right? But at a basic level, you are entitled for your doctor to be able to talk to a peer. Typically, when an insurance company denies something that is standard of care or is typically done, that's it. They have the peer-to-peer discussion and it is approved and it goes forward. If it doesn't, then there are other things that have to happen. Many insurance companies, before they will pay for a PET scan, will require a bone scan and a CT scan. So a bone scan, again, you're ingesting some kind of radioactive tracer that reacts with different things in your bones differently, so that the cancer, instead of lighting up on the scan, it shows up as black. And sometimes MRIs then are ordered to look at the organs more carefully. Here's the thing that I've heard from doctors. Doctors like different scans. They like looking at different scans. They like comparing different scans. If you've always had one kind of scan, they like to look at that other kind of scan. Your doctor is going to be the one to know what scan they need in order to see what they need to see. And they will work with your insurance company the best they can to get the images that they need in order to make good decisions. I know that some people get really, really, really upset when they can't get a PET scan, whether it's because they have Medicare or their insurance won't cover it or whatever. Doctors know how to deal with this. And whereas some doctors think the PET scans are the gold standard, are everything, they also can work from a CT scan and a bone scan. So the biggest thing with this is not to worry as a patient that the doctor is going to do what they need to do in order to get you the care that you need, in order to get the scans that they need. Yes, insurance companies are a bit of a gatekeeper when it comes to this, but if it's really necessary, your doctor knows how to get things covered, or their office does, right? Sometimes it's not the doctor in particular. But one thing that I have found is that when I get certain things over and over and over again, I get used to seeing the explanations of benefits. I get used to seeing the CPT codes on there and the things like that. So I keep all of that. So if I am at a different facility or my doctor wants to do something and, the insurance company has a new protocol or something, I can go back and refer to what's happened in the past if I need to. I have filed complaints with my insurance company. You as a consumer can file complaints as different tests are being as they're gathering data on certain tests before they get FDA approval. A lot of times organizations will not charge a patient money kind of as they're trying to get the whatever it is, whatever test it is, covered by the FDA. And so I think the thing that I've learned with all of this is that everything's negotiable. And if you need a particular test or a scan and your insurance company is not cooperating, or your doctor is struggling to get things approved, calling up companies and asking for a reduced rate, asking for them to waive their fees. First of all, every single doctor's office and medical practice is set up to do payment plans. And so if you need to spread out paying for your medical bills at $20 a month or $5 a month, whatever the payment plan that you are able to afford, doing that or setting that up in advance is always better than getting a call from a collection agency, right? So you know what you can do. You talk to your doctor's office and say, how can we do this? How can we set up a payment plan? And then you're meeting an out-of-pocket maximum by spreading out those payments. Most, if not all, cancer centers will have a financial aid office, or sometimes it's run through a chaplain's office or benevolent office, something like that. And so just like pharmaceutical companies all have a foundation attached to them, just about every major cancer center has a foundation attached to them. Additionally, if there's a social worker in the office, your doctor's office, or in the cancer center, social workers are the ones who have usually the most information on whatever local organizations provide financial assistance for patients. And there are lots of them. So social workers are a great point of contact. Sometimes you're a nurse navigator. Sometimes we'll have some of that information as well. But starting with the place that you receive your medical care from and working with them on how to meet those bills, that would be kind of the third step or the next step that I would suggest making. And then there are all of those organizations that have various funds. So the American Cancer Society has a fund. Um, and if you get on their mailing list, then you find out when that fund opens. And a lot of times there are many different funds. Some will be specific to, say, people of color, or specific to people with MBC, or specific to moms, or whatever the particular circumstances are. Getting on those mailing lists so that you know when there is a fund opening. Every single one of these organizations has an application process, and most are related to the household income. So they focus on the people at, say 100% or 400% of the poverty level seems to be the range that I see. So, and then there's other places where, you say I have this diagnosis and they give you a gift card, or they give you $100 whenever their funds open. So the long and short of it is there's no place, unfortunately, where all of this information is kept. Most people who are in this situation are, looking at every different possibility. Some social workers will be a really good contact for that. But at the end of the day, cancer is expensive. And financial toxicity is real because there's only so much money to go around. And so one thing that is, I think, very important for everybody to know is that you as a consumer are protected by the Fair Debt Collection Act. That is a federal act that if you are being called, i.e. harassed, by a collection agency or even by your medical office, if you say, I dispute this debt, I do not owe this debt for whatever reason, you don't even have to give a reason, they're no longer allowed to call you, harass you, send you letters. They have to stop, or they incur fines. The other thing that I always recommend, if you're going to be talking to insurance companies, your doctor's office, drug companies, whoever you're talking to, have a notebook. I have a notebook that sits beside my computer, and I'm immediately writing down date, time, who I talked to, and what happened. I always ask for confirmation numbers, whatever can get them back to whatever discussion that I had, because I don't know about anybody else, but once chemo brain happens, there are just things that don't stick anymore. It's complicated. No, it's confusing. So yeah, no, I mean, this is, unfortunately, it's one of the most confusing parts of things, because you have things like, and it says what happened to my mom. She went in for chemotherapy. They walk out and they're like, you owe us 40 grand, or you can't get chemotherapy. Oh, but by the way, if you would cross the street, you'll pay $50 out of pocket. And thank God they said that versus just accept it, because my dad was like, okay, take a credit card, fine, I'll pay. But the piece that a lot of people don't understand is that the prices for a medication change based on how you get it, right? So oral, like a pill, an injection, or an infusion, right? It's the same medication, but it's billed different ways. And then it'll be billed different whether you get it in a doctor's office, in an outpatient center, in the hospital, outpatient at the hospital, inpatient in the hospital. That piece is insane, because there's no way any patient could ever know those things except by shopping, basically. Or if there's a social worker who's very aware of that, like in the situation with my mom, they were like, just walk across the street. So, I don't, yes, it's a business, but I do find that most of the staff, they really want to find a solution for the patient. But sometimes it's just hopelessly confusing, because it would affect, millions of contracts that are being made all the time between all of these different entities. And it makes a big difference for, say, if you have brain mets. But, if that is something, if the cost of something, especially if it's not covered by your insurance policy, or you're going to have to pay some out of pocket, or you haven't met your deductible or your out of pocket maximum, and you need to have a payment plan, these are all things that are good to just ask about up front and sit down with the financial person in whatever place you are to work out a plan.